Welcome to our Women's Health podcast series. My name is Abigail Hole and I'm a Communications Assistant at Bournemouth University. Through this podcast, I'll be speaking with members of the Centre for Midwifery and Women's Health to learn more about women's health and the amazing research being conducted by the Centre. Today I'm joined by Sally Sheppard and Rosie Harper to discuss pelvic floor dysfunction. Would you like to introduce yourselves and your work with the NHS and Bournemouth University?
Hi Abby, wonderful to be here and thank you for having us. My name is Rosie Harper, I'm a clinical academic doctoral student at Bournemouth University and I'm currently in the final year of my PhD. As part of my PhD, I work as a clinical specialist physiotherapist at University Hospitals Dorset and I support both men and women with symptoms of pelvic floor dysfunction. I'm very interested as part of my role as well, supporting other clinicians to become a bit more research active in the NHS.
Hi Abby, my name's Sally Sheppard and I am service lead at University Hospitals Dorset for pelvic health physiotherapy, and I'm also service lead for the Dorset Perinatal Pelvic Health Project. I'm involved with Bournemouth University as clinical supervisor for Rosie's PhD, and I have a commitment to specific undergraduate physio lectures, and I'm currently a visiting fellow of Bournemouth University, so it's really lovely to be invited here today. Thank you, Abby.
Thank you for joining me today. In this podcast, we'd like to have more of a conversation about pelvic floor dysfunction, what it is, who it affects, and what new research and developments are on the horizon to support those who are affected by it. So let's begin by talking about what is pelvic floor dysfunction.
So to describe what pelvic floor dysfunction is, one of the places to look is the NICE guidance, which is the National Institute for Clinical Excellence. And NICE Guideline 210, which was written in 2021, describes pelvic floor dysfunction as a condition in which the pelvic floor muscles around the bladder, anal canal and vagina do not work properly. It's a public health issue, with 1 in 3 women experiencing symptoms at some point in their lifetime. Symptoms include urinary incontinence, emptying disorders of the bladder, fecal incontinence, emptying disorders of the bowel, pelvic organ prolapse, sexual dysfunction, and chronic pain. And the 3 most common and definable symptoms are urinary incontinence, fecal incontinence, and pelvic organ prolapse. So 1 in 3 is the takeaway message for how many women suffer with pelvic floor dysfunction symptoms.
At what age are people most likely to experience pelvic floor dysfunction?
So to answer this, I think we need to consider the risk factors and then consider which of those are reducible or modifiable. So the risk factors include very common things: pregnancy, certain factors related to the type of delivery, straining such as constipation or heavy lifting or having a chronic cough. Other risk factors are weight gain, reduced estrogen, ageing, connective tissue issues. So it's hardly surprising that 1 in 3 women experience unwanted urinary loss. And in terms of some of the other symptoms, 1 in 12 experience prolapse and 1 in 10 fecal incontinence. So to think about what age most people are likely to experience pelvic floor dysfunction, actually that's a whole lifespan, and prevention by increased awareness and use of the pelvic floor is a great well-woman habit, rather like us brushing our teeth. So it's quite hard to put an age span to those particular problems, but I think you can probably see that in that life course, they're highly likely to develop depending on the compounding factors that a woman might experience. And I think Rosie's got a few things to add to that.
Yeah, following on from Sally's points, thinking about that lifespan and looking at women across their life course, there are appearing, in the research, there are more predictable points in life where women might be reminded of their pelvic floor and to give it a little bit more attention. And back in 2021, there was a document released called the Women's Health Strategy for England that looks at healthcare service provision for women across their their life course. So when we're thinking about women around the perinatal period, carrying a baby for 9 months and going through vaginal delivery, that can have a huge impact on the pelvic floor. And whilst most recover well, sometimes during that period, people can get symptoms of urinary incontinence or pelvic organ prolapse. And it reminds women to sort of pay attention to their pelvic floor at that point in their life. Very similarly, around menopause with loads of changes in the body and also demands in life, that can be another point in life where women are reminded of their pelvic floor and these symptoms can arise again. So when we're thinking about the demographics that Sally and I see in clinic and how we can support our population, looking at that life course approach can be really effective, and actually trying to meet women before they come into these services to support them is also a nice approach.
And what are some of the key concerns raised by your patients who have pelvic floor dysfunction?
So with the men and women that we see in clinic, these symptoms of pelvic floor muscle dysfunction, dealing with symptoms of incontinence or heaviness or discomfort around the pelvis can have a huge socioeconomic impact. For the people that we see, it can affect their ability to exercise, so they can't participate in groups like they normally would because they might have an accident, and that can impact them on feeling a little bit more isolated at home or a bit more reclusive, which has an impact on someone's mental health as well. Thinking even further forward, if someone's not able to exercise, they're not able to get or maintain cardiovascular fitness, that can have a really large effect on life expectancy and quality of life and other healthcare conditions too. It can affect someone's ability to work. The work from home in COVID became very popular, but people do like seeing people in the office, and the ability to actually last the length of a car journey, get to work and have the available toilets is a big issue. I think with the nature of the conditions that we're talking about, there are quite a lot of feelings of embarrassment, feelings of isolation and shame, and that can be what really prevents people from, one, talking about it and going out and doing the things they want to do every day. We find that working as physiotherapists in the NHS, it actually takes a number of years before men and women come and actually access health services because they've been trying to deal with it on their own, and it's got to a point where they just can't cope anymore, but they don't want to talk about it, and if they may have realised there are services available to support them sooner. And whilst, as Sally mentioned, 1 in 3 people can experience these symptoms, it can feel maybe normalised, but it's not normal. So making sure we get that right is important from a health education point of view.
Picking up from what Rosie's just said, actually there are a few things. So the key concerns that patients bring to us in their appointments are usually very, very impactful. Our patients do tell us as well that there's a limitation on their choice of what they might do that day. Their concerns are very much about their day-to-day planning, and that can be very isolating. And it can also have an impact on intimate relationships. It can break down intimate relationships, but also it can prevent relationships from developing. But I think the thing to really hold on to is that both men and women get issues. We find a lot of our role is very much dealing with the key concerns, hearing them, and in talking them through. There are probably some other thoughts, Rosie, that you've got about concerns that our patients have.
Yes, something important to mention is that Sally and I wrote in for a recent call for evidence around birth trauma, and there's a known population that really struggle with these symptoms, and that is the postnatal population after they've had a baby. It's a known time in someone's life where there's so much change, entering into motherhood, going through a delivery, learning how to look after a baby, as well as loads and loads of changes internally that can have a massive effect on someone's mental health. The appearance and the prevalence of these symptoms when you've had a baby can just, one, remind women of what may have been quite a difficult birth and may contribute to birth trauma, and two, prevent them from doing the things that they feel like a mother should be able to do, like lifting the baby without leaking and being able to not be in pain when lying in bed. So it's a recognised population that we see a lot of clinically, and it's important that they get the right support and education at that important time in their life.
And what medications and treatment plans are currently available through the NHS to ease the symptoms of pelvic floor dysfunction?
Treatments tends to be education, knowledge, finding your pelvic floor, knowing you're doing a pelvic floor contraction correctly, doing enough of them, doing them often enough, doing them regularly, building a habit and keeping it as a lifelong routine. That's first line treatment. And treatment can be effective for 85% of cases to give improvement and for 60% cure, which is great. But the flip side of that is that there's 15 to 40% who don't gain from that, and there's an escalation of care. So there are surgical options, an injection that might help to bulk a particular bit that supports in a particular way that helps with continence. In terms of medications, which you asked about, the very first thing to always be checking is that there's not a urine infection, because a urine infection at its worst can cause leakage. So you can think that you've got incontinence when actually there's an infection. But the GPs are aware of that, and exclusion of a urine infection is very typical. There is another type of medication that can help a certain type of incontinence, but it's not reached for first line. Something called bladder training is always tried first, which is about getting your fluids right, drinking the right thing, drinking the right amount, not going just in case, and just trying to get your bladder into a good habit again. The actual causes for it are still not fully understood, but a urine infection has to be excluded first.
Another type of medication that some women find effective are topical estrogens. And topical estrogens are a small tablet that you can insert into the vagina, or a type of cream that you can use around the vulva and vagina to replace just a very low dose of estrogen around that area. For most women, it's safe to use under the supervision of a GP, but it's important to discuss that with your GP if you're thinking about it. We tend to find that using topical estrogens or a vaginal moisturiser and pelvic floor muscle training go hand in hand to plump up the muscles, support the bladder, and help with the elasticity of the tissues to improve symptoms.
Are there any recent findings related to pelvic floor dysfunction which may impact the future treatment of patients?
There's a project that has gone on from NHS England for the last 3 years to improve knowledge and awareness of pelvic floor education through pregnancy and improve access to postnatal physiotherapy care after delivery across England. That's something that's in place or being put in place in all regions. And Rosie's PhD is really looking at something very exciting in terms of what we hope is going to be a recent finding. So, Rosie.
In the NICE Guidelines 2021, it does recommend that pelvic floor muscle training mobile apps can be used to support women with their pelvic floor muscle training, which is an important point and very exciting for us as clinicians to consider when we're looking to encourage women to self-manage and support themselves. As part of my PhD, I'm looking at ways of supporting women and reminding women to do their pelvic floor muscle training, because clinically what we hear a lot of is that people find it difficult to make the time or forget to do their pelvic floor muscle training. So by reminding and supporting women to train often enough to do their exercises that's enough to make a difference in their symptoms has a big effect on the population. So published last year was a systematic scoping review looking at the use of online or digital prompts and cues as a way of supporting women and reminding them to do their pelvic floor exercises. And excitingly, this was found to be more effective than just usual care alone, which is you see a therapist and you go off and you do your exercises, but those gaps in between appointments are times where those exercises can wane because life can get in the way. So perhaps using digital apps as a way of supporting women is an exciting new way of offering a supervised form of pelvic health physiotherapy. The second publication was looking at a patient and public involvement study on social media. One of our colleagues, Elaine Miller, cleverly created humorous digital content on Instagram as well as other social media channels that created playful reminders for women in the 3-month lead up to Christmas to do their pelvic floor training. And from this patient and public study, we found that the use of humour is actually a very persuasive way of engaging women and encouraging them to do their exercises. But what was also interesting from that study was perhaps social media isn't the best way of capturing adherence, because it's hard to know just if someone likes or comments on a post, have they actually done it? Which again directs us back towards apps as a more robust way or another way of capturing exercise adherence.
I spoke to Anna Marsh in my last podcast, and she was talking about how social media is kind of maybe used in midwifery to recommend resources and things. Perhaps pelvic floor dysfunction education is something that the apps might benefit from kind of integrating with.
Absolutely. Anna Marsh is doing such exciting things around the use of social media, and she's had her own publications in that area which are brilliant. And you're absolutely right, you know, that support and signposting and that more robust capturing engagement and adherence, there's definitely a way for them to go hand in hand. And us as clinicians are being encouraged now more than ever to get more technically literate in using social media and putting things online. So it's that kind of fusion of these different sectors that could be very exciting for certain demographics that are digitally literate and are able to access online resources to support them. And I think what Sally's a very big advocate of, quite rightly so, is also recognising that there are populations that don't have access to those online resources. So how can we support them as well? Thinking about health inequalities, and especially in Wessex, we need to make sure we're supporting everyone with this.
I'm on a campaign that's just been sort of lifelong to get a pelvic floor bus that's got pelvic floor reminders on the side of it, and it's got a clinical room inside it, and it's got some clinical staff in there. We get to places where there may not be digital users, but we also bring care to the population as well.
Can you tell us a bit about the Women's Health Hubs in Dorset?
I can't speak for the Women's Health Hub project, but we have been involved as a stakeholder interested in supporting the Women's Health Hub project, because it's a fantastic project that's happening nationally as part of the Women's Health Strategy, and we have a really dynamic team in the project team for Dorset, so we're very, very lucky. The engagement that they've thrown open as wide as they can to as many stakeholders is huge. And a virtual resource is a more cost-effective way of then being able to get the spread as wide as we possibly can.
I also think perhaps if someone's feeling a bit embarrassed or unsure about consulting someone about symptoms they might be having, it's less nerve-wracking to join an online call sometimes than to be in a waiting room. It can be quite an anxiety-inducing environment to be in.
Absolutely. And while we've touched on the importance of humour in this, the very, very serious side to this is that it's simply not funny to suffer with this at all. The barriers to accessing care are exactly as you just beautifully described. You don't want to sit in the waiting room and be called in by the person who treats that problem, because you might be identified and you feel very uncomfortable in that situation. To be able to provide that virtual service, I think, is inspired rather than limited or restricted.
And previously, I think it's been assumed that sexual health clinics are for contraception rather than a broader scope. And I know that pelvic floor dysfunction is something that they can actually refer on to through those services, which is really good in opening that accessibility up to the wider community.
Yes, absolutely. And just knowledge about what the sexual health clinics do provide is very empowering, because then it becomes somewhere that you might choose to use. And the sexual health clinic team are part of the Women's Health Hub stakeholders. And the other fantastic thing that the project is doing is it's bringing together groups of us that are very specialist in very small areas of work, but we're getting to know our counterparts, and we're looking at exactly that, how we can map ourselves together so that the patient who walks through our door can easily then access another service that's relevant.
And why is it important we have more public conversations around the subject of menopause and pelvic health dysfunction?
For so long, women's health research has been silenced. There's been a lack of research and a lack of attention and support for a population that are struggling So it's really, really important that people feel that they can talk about these symptoms. So it's important that women speak about these symptoms to their friends, to their family members, to their GP, to their midwife or their health visitor in the perinatal period, to directly combat that shame and taboo that has put so many people into more siloed, silent spaces that only serves to exacerbate the problem and actually lower someone's quality of life and prevent them from accessing health services. In another way, by educating some people, in Dorset, Sally's done such a great job, and there are future projects looking at train the trainer, speaking to yoga instructors, speaking to hairdressers, to educate people in the public who, when someone comes forward and says, I actually notice that I leak every time I cough and I completely soak through my trousers, saying, oh, actually, did you know you could do this? So it's allowing other people to support others with their conditions and realise that it's actually more common than they think, and creating that support and community around it, which I think is very, very important.
To finish each podcast, I've been asking guests, what conversations about women's health do you feel we need to be having more of, what we're not talking enough about?
So I think the most important message that we'd like to come out of the podcast would be to educate women in how to find their pelvic floor, how to do it, how often. So we're kind of conveying what we say every day in our clinics to get the right health information across. So we're thinking about how to find your pelvic floor. It should feel like you're holding in wind in a really busy lift. So it's a puckering in a very small lift that starts around your bottom and that can sometimes travel around the front as if you're trying to close the vaginal opening, and you feel a small lift up inside before letting go. Some people, some yoga instructors in particular, describe it as a zip that starts from your tailbone and zips up around your bottom, around the vagina, and up and in before letting go. It's very, very easy to get other muscles kick in, but actually by isolating that very small lift in between your legs is key. It's as important to let go as it is to squeeze. You want to feel like you're doing both to get coordination and function of the muscles. You want to be doing 10 of these squeezes daily. And then when you finish completing those 10 repetitions, you want to practice in squeezing, holding for 10 seconds, and then repeat that for 10 times. That takes under 2 minutes to do. And if you can do these 3 times a day, you're meeting the national guidelines and you're doing really well with your pelvic floor. It is a tall order, but thinking 10-10-3, 10 squeezes, 10-second holds 3 times a day, you can make a really big difference in 3 months to your pelvic floor function. But actually what we found from the Drive By Christmas campaign on Instagram, some women find actually the effects are even quicker than that. So that's motivation to do it. Remember that every squeeze counts, and start small. When we're thinking about habit creation, going from 0 to 100 normally isn't sustainable. So think about things you do more than once a day. You think pelvic floor and pair it with something to build a habit.
For the weak pelvic floors that might be listening, when the pelvic floor muscles are weak, the sense of squeeze and lift that Rosie's described, it sometimes lacks the feeling of lift. And sometimes it barely feels like a squeeze. I have patients who say it feels almost like a blink. It's that light, but they can feel something in the area of the back passage puckering slightly. And they'll look at me and say, is that it? And the thing to do in those situations often is to lay down into a comfortable position. Put a pillow underneath your knees, get comfy. So think of being in bed, and then try your pelvic floor, because you don't have gravity pulling down on it. Sometimes in sitting, our glutes are too much underneath us, and if you just spread them out a little bit as if you were sat on a nest of eggs, a little bit wider, that sometimes helps you find it in sitting. Or just adjusting your position so you're leaning forwards or leaning backwards. Everybody's different. We're human. We've all got different lengths of muscles attached. But trying these exercises, see them at first as just feel it, find it. Then you can build up to exercise. Then you might feel the squeeze and lift. But don't worry if at first all you can do is feel it, find it, and then it seems to disappear. Come back to it, and it'll keep coming back. I remember a very memorable patient in her 80s who could only contract it a couple of times laying down. And it took her about 9 months for her to come back into the clinical appointment and say, guess what, I'm doing it now and I'm standing up and no one knows. But it's taken her a long time. But I did promise her, she said, please tell people to keep going because it does take time. So this is a great opportunity to share that.
Thank you so much for joining me on this podcast. Please join us in our next episode where I'll be speaking to Sarah Stride, Senior Lecturer in Midwifery, about midwifery and unforeseen circumstances. If in the meantime you'd like to find out more about the Research Centre, please visit the Bournemouth University website.